I get so many questions about egg donation and how egg donors are screened, how they go through the process, what's important for the clinic to see, and what makes a good egg donor. So I decided today to invite Dr. Briana Rudick, who is Director of Third Party Reproduction at Columbia University's Fertility Clinic. And she will tell us all of the things that you need to know about the nuts and bolts of egg donation. What makes a good egg donor? How do you know that an egg donor is going to produce eggs successfully? What do you have to think about with regard to the medical and emotional and psychological needs of everybody involved? And ultimately, how to really keep your eye on the prize, which is a healthy baby. So join us. I think you're going to really like this episode. Welcome to Building Your Family. This is a podcast about fertility treatment, donor conception, surrogacy, and all the ways the modern family is built. My name's Lisa Schumann. I'm your host. I'm an author, a researcher, a therapist, and I'm delighted today to introduce you to somebody very special, Dr. Briana Rudick. She's a wonderful doctor, and she's head of the third-party department at Columbia University's Fertility Clinic, and that means that she's in charge of surrogacy and donor conception for that hospital clinic. And she's done so many things with her career. She's published papers. She's been in all sorts of magazines. She's done amazing things with her career. And she's also, which is not in her bio that you will see online, but I will let you know that she is also an advocate for ethics. She has been written up recently in many publications because she really stands by her strong moral code and does the right things for patients all the time. So you will really, really feel so warmly about her. By the time we finish this episode, you will be amazed at how she looks at things. In fact, she seems to have coined this idea, and we can talk about it, co-maternity, which is, as many of you know, reciprocal IVF. But I think it's such a warm, lovely term. And of course, that's something that Dr. Rudick does so well. And today we're going to talk specifically about third-party reproduction and egg donation in general. So for many of you who use an egg donor through a clinic, or even if you use an egg donor and it's someone you know, these are really helpful things to know. You'll need to know how this person is screened, what the criteria are, and the things that you'll need to know to make sure that they receive the best care possible, and any red flags that you might want to be thinking about. So thank you, Dr. Rudick, for coming. I really appreciate your time and your effort coming in today. And tell us a little bit about what we need to know when a donor comes into your clinic.
Yeah, well, thank you for that really lovely introduction, Lisa. So there are a number of things that we look at when a donor comes in. We're looking at the history that they presented on a number of questionnaires, including family history and their own medical history. Many of our donors, or almost all of our donors, are really between the ages of 21 and 32. So a lot of them don't have medical issues yet. We don't know what's going to happen in the future. So we're really looking at family medical history as kind of one of our starting points to determine, is this a donor who we feel like has a very low genetic risk, who will be matchable, and who a recipient will feel comfortable with. Once she comes in for medical screening, then we can start to pay attention to things that are more specific to her. Are there any abnormalities with the uterus? Are there any abnormalities with the ovaries? What is her GYN history? If she has a GYN history, what is her OB history? Has she ever been pregnant before? All of these things are things that we factor in when we're deciding whether it's okay to proceed with a particular donor.
Mm-hmm.
And of course, as part of that screening, we look at fertility testing. So we want to make sure that the egg count looks like it would be in a good range so that a round of stimulation could be helpful and could be successful.
And why would it be important that an egg donor has a healthy uterus, or maybe doesn't have fibroids, or things that maybe we wouldn't necessarily think we would need to worry about with an egg donor?
So fibroids are pretty common. I'd say up to 50% of women have them, and they're not mutually exclusive with this process, and they certainly aren't mutually exclusive with pregnancy either. It does pose more of a challenge when they get very large and when they get bulky. That can block access to the ovaries if we're trying to do an egg retrieval. So it might mean that we're more limited in terms of our egg yield on one side. And then they also might grow with the medications that we're using for stimulation because her estrogen levels become pretty high during the stimulation. So for her own health, like she should be aware if you do this process and you do it multiple times in particular, that it's possible that those fibroids can grow and that she might develop symptoms of fibroids, which can mean very heavy periods, sometimes even spotting between periods. So, both for her own health and for the sake of success with the cycle, we want to make sure that the fibroids aren't an issue. If they're small and they're kind of, not too close to the lining of the uterus and they're not blocking access, like then it's still okay to proceed, but we just want to make sure she understands like this could grow. This should be on your radar. This is something you should talk about with your GYN.
So I knew that I characterized this whole process that we were going to go through tonight correctly, because clearly you are so concerned also about the donors, not just
Absolutely.
about how they produce. You really want to make sure that they're going to be healthy, and this is not going to affect them in a way that's going to be problematic for them down the line.
Right. Exactly.
And what are some of the other things that you look for as you see donors? Are there other things that you'd be concerned about?
We do kind of the same way that we do really for all of our patients. We do fertility testing in the form of ovarian reserve testing, which is an overall marker of egg count. When we see a donor and she's young, typically an egg count will be in the higher range. The egg count will really correlate with the number of eggs that we're getting. And so we really want to choose donors that can tolerate a lower dose of medications instead of needing higher doses. And we want to choose a donor that ultimately can get us a large enough number of eggs that we think that there's a good chance of getting viable embryos from that batch of eggs, because not every batch of eggs will give us viable embryos, and so typically we have cutoff points for blood tests called an AMH level in terms of what would be acceptable for the egg donation program versus what would not be acceptable for an egg donation program. The AMH level is kind of like an SAT score for how many eggs are remaining in the ovary. So above 2 would be ideal, and that would be kind of our minimum. 1 to 2 is borderline, and less than 1 is low. If we're not going to cycle a donor or not have her be part of the program because the AMH level is low, that will be a discussion with her as well, because we want that also to be on her radar, particularly if she's not had kids before, been pregnant before. This is really an opportunity for her to learn about her own fertility as well.
And what do you do when you see a donor and then all of a sudden the results are not what you'd hoped for? It must be a pretty difficult conversation to have with her about her own fertility.
It is a difficult conversation. We try to stress that that doesn't necessarily mean that she will have trouble conceiving, because when she's trying, her ability to get pregnant from month to month is more dependent on that one egg that she's ovulating, rather than is that one egg coming from a group of 20 follicles or is it coming from a group of 5? So her ability to get pregnant on her own is more related to age at the time that she's trying to conceive. So on the one hand, I want to be very reassuring about that, but in general, we will advise all of our patients by age 34 to be actively getting pregnant or freezing something, just from a fertility preservation perspective. And so those same kind of rules would apply to her. If we are seeing indicators that there may be some kind of issue with fertility in the future, such as a lower egg count, like then we may consider doing it even earlier than age 34. So it's something really for her to keep on her radar as she gets
Mhm.
closer and closer to where she figures out what she wants to do in life and how she wants to family plan.
And then if that happens and there's some indicator that she's having some difficulty or the test results aren't what they should be, would you say she's probably not a good candidate, or should she come back another time? Because I know that sometimes people get their heart really stuck on a particular donor, and it's
Yeah.
so hard. Some of the people that I say, you can fall in like, but don't fall in love,
Right.
because we don't know. So that's gotta be difficult also.
It's hard. I mean, some of it will be a conversation. Like if this donor is already matched with someone, some of it really will be a conversation with the recipient. Hey, we noticed that her egg count testing looks borderline. So we're not going to be expecting something like 20 to 30 eggs. I've definitely had donors who consistently are 10 to 15 eggs every time they donate, who are successful every time. So there is still the separation between egg number and egg quality. But I think it's all about just informing everybody ahead of time and seeing how comfortable they really are. There are definitely recipients who feel like they are attached to that particular donor, who want to proceed even with borderline numbers. And that's okay as long as everybody's informed.
So that would be, in particular, relate to something like a sister or a friend, some sort of known person who somebody
Exactly.
really has their heart set on. That might be difficult, and because they want to use someone who maybe not be the best candidate, but somebody that they really feel attached to.
Exactly, particularly in known donor situations. Like many times we're making that call, whether it's an age that is older than we would typically use for an anonymous donor, or whether it's an egg count that is lower than what we would typically use for a donor. So I think, as long as everyone is counseled and as long as everybody is aware of the possibilities, it's an okay thing to do. It's just a matter of making sure everybody's comfortable.
And then what about other things like lifestyle? If the donor smokes, or I mean, a lot of young people are vaping these days or using marijuana and other substances. How do you advise the egg donors?
That's a tricky one. And I think a lot of people are under the impression that vaping is a healthier option than smoking. And in some ways it might be, but in terms of the toxic effects of like nicotine, it is not quite a difference. It's actually a higher concentration that's being delivered. I think overall, tobacco is probably the heaviest hitter when it comes to female fertility. It definitely is associated with a lower egg count, a premature decrease in egg count, and it affects egg quality. So, egg
Wow.
donors who are smoking, like that's definitely a risk factor for a cycle that just isn't going to go very well, or egg quality that's worse than we would anticipate for their age. There's also a medical risk to them because the combination of tobacco and higher hormone levels can lead to blood clots.
Oh, well.
And a blood clot that starts in the leg can travel up to the lungs. And, this is why we worry about donors on birth control pills and smoking. Not a good combination in terms of blood clot risk. And so we want to make sure that she understands that there's some health risk there for her if she's smoking throughout this process. Now, the life cycle of a new batch of eggs is really about 3 months. So she really wants to, optimize her lifestyle as much as possible for those 3 months leading up to the actual egg retrieval process.
And what about other like environmental toxins? Do you worry about those things? Because I know that's very popular to worry about these days.
We do. We just don't have good enough data here.
Hmm.
I think you had mentioned cannabis before, like that also. We don't have great data on cannabis. There is some that it affects sperm quality and motility.
Hmm.
And anytime we're dealing with a substance that affects sperm, we automatically get suspicious that it's something that can affect eggs. But we still don't have great data there. In general, we will advise patients to just not smoke cannabis like around the time of this process because we're concerned that it might affect egg quality. But in terms of the environmental pollutants out there, it's a lot of them, and that's a variable that's very hard to control for. That is something that can change from cycle to cycle because we do see a lot of variability from cycle to cycle, even for donors who were successful before in the past. So that's
Wow.
a very difficult variable
Hmm.
to get a hold of. Like we hear about microplastics, we hear about environmental toxins and endocrine disruptors. I don't think we have enough data to pinpoint exactly what's going on, but there's definitely the suspicion that those things could impact things like egg quality.
And what about things like makeup and perfume and all the things that I would imagine we worry about in the lab, so maybe we should worry about
Right.
in the body.
I mean, it's a fair question. We don't have answers to this yet. There's a lot we still need to know. I think
Hmm.
the one kind of cream or application that we tend to veer away from is anything containing the retinol products because that's a category X during pregnancy. I don't think we
Mm.
have good data that it affects egg quality, but we're just very vigilant about that particular one because we worry maybe it could be stored in tissue somewhere. So I think overall that's the one that we tend to focus on, but you're absolutely right. Like a lot of the things that we are putting on our skin on a regular basis that we don't have true safety data for, like it's possible those things are affecting things and we just don't know it.
And how would we think about that in terms of the eggs? Would it just make them potentially less effective? Could it cause other problems down the line? What are your thoughts? I know it's hard to know.
It's hard to know. I mean, I think more likely a quality issue. Usually when we're talking about egg quality, we're really talking about like the viability of those eggs. Like, do they make good embryos? So when we talk about egg quality, our because we don't have an objective measure of egg quality, there isn't a way to know ahead of time how a donor's eggs are going to perform in the lab. We look at how those eggs do once they're fertilized and once they're growing to the embryo stage. And it's that embryo development that really tells us a lot about egg quality. So if embryo development happens very well and we get a very good number of embryos, that implies that egg quality must be good. If embryo development is very low or we're seeing very poor quality embryos, then that really implies that, egg quality probably was not very good. So a lot of the energy that drives an embryo to grow and develop normally is coming from mitochondria in the egg.
And at some point, we probably will be, it'll be more common to grow those eggs outside of the body now, right? How far away are we from that being just kind of something that we can look at as a regular custom in fertility clinics?
I had a patient who just asked me about that today, actually. This concept of in vitro maturation, where we don't need the doses of medications that we use. We can just take eggs that are immature and then mature them in the lab. I don't think we're there quite yet. And traditionally, when we've looked at success rates with in vitro maturation, it's not been as high as what we do now.
Hmm.
But that's the promise, is that it can be a nicer experience for everybody while still maintaining a high chance of success. And particularly for donors, many of them have a high egg count. So making them feel better in this process might make it seem like an easier process for them, and maybe we would have more donors. So there are many repercussions to that if it becomes as successful as the technology that we have now.
Imagine your beautiful future. You're snuggling with your child. You feel so connected to them. Your friends and family are so happy, and you have everything that you've ever wanted. I want this for you too, but I want more than that. I want you to feel secure knowing that you've made the best decisions, not just short term, but long term for your future family. Wherever you are on your journey, whether you're choosing a donor, choosing a clinic, learning how to talk to your donor conceived child about their origins, all of these decisions will have wider implications for your future. And I want you to have the right resources so you can feel empowered and confident at this very important time in your life. That's why I'm so excited to introduce you to Building Your Family. It's the only expert-guided platform designed for parents and parents-to-be using reproductive medicine. We provide unique strategies that you won't find anywhere else to make your path to parenthood smoother and more informed. And that's why our approach is about offering practical and actionable steps that you can use right now. Whether you're just starting out or already deep into your process, Building Your Family is here to guide you with expert advice, specialized education, stress reduction strategies, and a community to support you every step of the way. We can't wait to see you inside. As you're looking at all of these things, there's probably a lot to consider along the way and a lot to talk to the donor about. And the donors may have these questions too, I'm assuming. How do you balance that with the patients? Because the patients are also worried about all these other things, like, does this person look like my grandmother, or, whatever criteria they have in their heart. How do you kind of balance it? Because ultimately, the patients need to go home with a healthy baby, right? And so
Right.
that typically, I would imagine, should be the highest priority for most programs, but the patients come in with their own agenda and issues that are a priority for them.
It's hard. That balance is one of the hardest things. We are advocating both for donors and for recipients. And so, to some degree, you need to be a really good mind reader, which is hard to do.
Yes,
I
impossible.
think, I know. I think if you are understanding of where people are coming from emotionally and what is driving their response and their questions, I think that makes a big difference. I think it is possible to be an advocate for both. I think it just requires an acknowledgement that if there's a difficult conversation, that is something that you're willing to have.
Hmm.
if a cycle needs to be canceled, that you are willing to do that and you're willing to do it in like a nice, respectful way. So I think it's just remembering that both of them are patients. You want to
Hmm.
be respectful to both, you know, and donors want to be successful as well. Like they also are somewhat invested in this process. I've had donors who come back to cycle for a second cycle for a recipient who needed more embryos from that donor. And she went out of her way to be healthy, like extra healthy the second
Mm.
time around, veggie juices, like just out of her way, had never even met
Wow.
her, but she really, really wanted it to be successful. So I feel like
Nice.
sometimes you see things like that and you realize like it is possible for everybody to be kind of facing the same direction.
That's beautiful. That's so nice.
Yeah.
And on that note, I think it's good for people to kind of know you've seen so many egg donors that egg donors are really in it with their heart. We're not just looking at people who we're going to just pay and say, okay, we're paying you for your eggs. They really want to do this thing to help other people.
Right. I mean, we have a rather extensive questionnaire that we give them, and some of it is just the routine FDA questions, but there's a whole area towards the back of that where we really try to get into who are you and why are you doing this? Who's a hero in your life? What's your favorite book? What do you like to do?
Hmm. Hmm.
Do you know anyone who's done fertility treatment? Most of them can cite somebody in their life who has required this or a real emotional reason for doing this. It's not usually just a monetary thing for them. I think there are easier ways to make this money, to be quite honest.
Hmm.
So I think a lot of them are driven by either a need for more information. Some of them want to know about their fertility information. Some of them are in the medical field and are genuinely interested in this.
Mm.
But most of them have some kind of personal experience. They know someone who has struggled or they feel just incredibly lucky in their life to be where they are and they understand the importance of family. But most of them really have like a true like reason for doing this and for choosing this route.
That's great.
Yeah.
And as donor conceptions changing, we just the laws just changed in Colorado, and I suspect this is going to unfold around the country. How are you finding that the recipients and donors are handling this idea that this is a lifetime decision? This is not just going in for a blood test.
I mean, I think when it is handled with like the right amount of grace and the right amount of preparation, everyone seems actually much more open than than I initially thought everyone would seem.
Mm,
So I think a lot of that goes to the counseling, like the incredibly important counseling that you do on a regular basis, Lisa.
thank
I
you.
think that's really where the crux of this is going to be. I'm amazed sometimes that when I ask donors, like, how would you feel about not identified, or how would you feel about meeting the recipient one day? Like, people are inherently more open to it. It's so hard to predict what someone's mindset is going to be 18 years from now, you know? And so
Hmm.
I think leaving doors open is ultimately an important part of this process. And a lot of that has to do with good counseling. And what does it mean to have
Hmm.
contact with a donor in the future?
Yes,
What does it mean to have contact with a genetic child in the future? So I think like that's where a lot of the focus in the future is going to have to be, especially if the concept of anonymity like does become illegal in the state.
yes, yeah, absolutely. And then as we move forward in this way, I would imagine because there's more to think about and there's more to consider for your future, I would suspect that donors, and you can tell me what you're seeing in your program, donors are also probably feeling a little bit more invested because there is all of a sudden this now connection with this other family person, extended family out there in the world. It's not just like they may have used to think about it like a medical procedure.
Right. It's closing the loop for them a bit more. Like now there's an endpoint, and even if they don't exactly know what the endpoint is, they have to conceptualize it a bit more now. If they're thinking about what could the possible arrangements be like later on or 18 years from now when the child reaches a certain age. So I think, you know, having those thoughts and having those discussions now, even if it's not the most comfortable of discussions, will ultimately benefit everybody in the long
Yes.
term.
But I would imagine the flip side of that might be that if it didn't work out, if their AMH is not in good shape or there's some other indication that they wouldn't be a good egg donor, but good candidate for egg donation, that they may be more disappointed than they would have otherwise.
Right. And so that's why, that conversation with them has to be both informative, but also like very understanding,
Yes.
and many times I will offer like a consult, like, let me call you, let's discuss this,
Mm,
and that way you can have your questions answered. I'm like very open with my email with all of my patients and all of our egg donors. So
that's
anytime they
great.
have a concern or a question, like they can always email me and that way they can get some information real time.
That's wonderful. And what are there other things that we haven't touched on yet before we go into the next topic about other things that patients should be thinking about with regard to their egg donors? Are there other things that we have to be concerned about that would prevent somebody from being an egg donor?
I mean, I think, we always look at like the responsibility side of things, especially for a donor that's never donated before. When we're meeting a donor for the first time, like how responsible does she seem? Has she ever had a problem with something like a birth control pill before? Like any issue that we see that could be an issue, we want to kind of take care of early on so that we're not getting to a point in this process where we feel like we can't go back. I have a lot of donors who come to us saying, you know, I'm not sure if I can keep my IUD in while I do this process, and that's okay. We cycle lots of donors with IUDs, so that's okay. I also have a lot of recipients who seem to think that we are doing some kind of test for egg quality for donors. And I think it's
Mm,
important for recipients to understand that tests for egg quality do not exist. The assumption is just because she's younger that most of the eggs are of good quality, but there are still poor quality eggs in there. It should just be a lower percent. So I think in
mm,
general, a lot of people have this idea that that's a testable phenomenon ahead of time, and it really isn't. This is, even with the cost that it is, very much an investment and a chance as much as any of our other treatments are, and we try
yes.
to, put as much favorable stuff into that equation as possible by doing things like AMH levels and doing things like follicle counts, but we never know how a donor is going to respond to medications. It's a very hard thing to predict at the outset.
And what if she has some other difficulty, like, you know, polycystic ovarian syndrome or endometriosis, or has had histories of, any kind of trauma or other issues that might have come up for her gynecologically during her life?
I mean, these are good questions. They're individualized. I've definitely had some donors who come to us like virginal, who've never had any kind of vaginal penetration before, and we worry a little bit about
Wow.
that because a lot of the way
Mm-hmm.
that we monitor is with transvaginal ultrasounds. So if that's going to be a source of stress or a source of discomfort or like a source of trauma for her, like we don't want to impose that on her, and so
Mm-hmm.
we want to make sure that she understands really what the process is before she gets into it. We've definitely had a good number of donors who probably have PCOS. Many of them don't have an official diagnosis, but we just hear, they had irregular cycles. There was the suspicion of it a long time ago, but then, one of their doctors put them on birth control pills and they've just been on them ever since. So sometimes it's not something that's fully flushed out. Many times we're the ones doing the flushing. So they just haven't
Mm,
gotten to that point in their life. I would not say that PCOS in and of itself is a reason why they could not be a donor, but it's definitely something that we have to factor in. Usually, those donors tend to have a very, very high egg count. And so they're at a higher risk of something called hyperstimulation syndrome. And that means more health issues for her in the course of doing treatment. That means she may feel more uncomfortable. And so that's something that she really has to understand and she has to feel comfortable with. Now, we have many measures that we put in place to try and prevent the moderate and severe forms of hyperstimulation. But even with those measures in place, it's still possible. And so we want to make sure that she's comfortable with that. I think, even the insurance that we get for donors has recently put out, a new rule that if they ever had treated hyperstimulation, that they're not going to get insurance anymore. So like
wow.
this is now like a new consideration. Like if we have a
Oh my
donor who has
gosh.
documented ovarian hyperstimulation with a prior cycle, like we cannot actually cycle that donor anymore. We're not going to be able to get insurance. So it's too risky. So we want to
Mm,
make sure that we're identifying anything that would really increase her risk of complications in this process. Endometriosis is tricky because endometriosis is more about her own fertility. Endometriosis is associated with like a lower egg count than normal, but not always, and lower egg quality than normal, but not always. But the concern with endometriosis is that it's very hormone responsive. So if she's doing this process and she's doing multiple rounds of stimulation and her estrogen levels going up every time, like that can really feed the endometriosis. So it may
Mm.
not be a great option for her. Additionally, if she has endometriosis in the ovaries, like then the retrieval itself as a surgery is riskier, like in terms of risk of infection, things like that. So I would say endometriosis would probably be one of those things where we would say this is probably not a great option for you unless you are doing it for yourself.
There's so many things to consider,
Yeah. All individualized.
all individualized, and people who are using a known donor, they have to think about all of these things as
Right.
well.
Right.
So, Dr. Rudick, once we're past the egg retrieval and you feel happy with the amount of eggs they have and you start to create embryos, what about PGT testing? Because a lot of people are wondering about that. I know the reviews are mixed right now about PGT or not for donor eggs.
So PGT, like any other medical test, really depends upon a pretest probability. So if the chance of making all abnormal embryos is low enough, then PGT won't necessarily improve your chance of success. It's really useful as an embryo selection tool. So, in cases where we have donors, all of whom are between 21 and 32 cycling, most of the time when we use PGTA, we're going to find that most, if not all, of the embryos are normal, which looks very nice written up in a report. But then we're kind of thinking maybe we didn't need to do the biopsy for those embryos. The overall risk of biopsying a strong embryo is low, but there is some risk with the extra manipulation. And so I think this is why we've not seen an improvement in success rates with PGTA when applied in a donor egg population. If we're in a situation, however, where we ultimately plan on transferring those embryos into a gestational carrier or a surrogate, like that's usually when we want to make sure that PGTA is being used so that we can avoid transferring an abnormal embryo into a gestational carrier.
So, I suppose the next question a lot of patients might have, well, what's the difference?
I think some of it has to do with just patient autonomy and what you can do with your own body and making decisions for yourself versus for another human being. Many of our
Hmm.
gestational carriers might live in states where it might be harder to get a termination if they find out that there is an issue with the pregnancy or a chromosome abnormality. It really adds a whole other layer of just difficulty all the way around if a gestational carrier is suddenly in the position of having to terminate a chromosomally abnormal pregnancy. So avoiding that kind of situation becomes paramount in this process.
So, do most patients say it doesn't matter to me, or most patients asking for the PGTA with their donors?
I feel like probably at least half of them are still wanting to do PGTA. Sometimes patients are at a point where they've just been doing this for a really long time. It's been a very stressful process. They just want to try and make sure that they are making the most of their time with every embryo that they transfer. I think sometimes patients are interested in sex selection, and that's the only time to truly
Hmm.
do that. I think if there's any concern about sperm or if there's a history of translocations for the male, I think those would all be reasons, or even a genetic issue for the male. Those would all be reasons to still do PGTA. So I'd say we still have a number of patients who want to do it because they just want to know that they're working only with normal embryos. I just think it adds a whole other element when you're now working with a gestational carrier.
Yes. And then what about the donors? As they move along in this process, there's only a certain amount of times that they should be donating. Is that correct?
Per the American Society for Reproductive Medicine, 6 is
Hmm.
kind of where that guideline stands. It's not an absolute. So we've definitely had donors who've gone past that 6, especially for the purposes of creating a sibling for a recipient that they've already donated to. Some of that is because we don't have long-term data on what it means to donate like beyond 6 times or to donate like many, many times. And so there is still a concern about that lack of information. And even though the risk of complications, like the risk of complications from an egg retrieval is less than 1%, but each and every time you do it, there's still that risk.
Hmm.
So it's something that we still want to minimize as much as possible for our egg donors.
I see. And a donor who donates that many times, I would imagine, really feels very strongly about helping other people. Maybe they aren't going to have children themselves and they really want to help other people have kids. Are those the sorts of things that you're seeing,
Those are the sorts of
the
things I'm
donors?
seeing. Sometimes we have
Hmm.
donors who've had kids like early in life and they know they're done,
Mm.
and so they don't feel as nervous about donating like that number of times. So it's kind of a mix of things.
But it sounds like in all of this, you've really thought about so many things with regard to patient autonomy and concern, and also safety for the donors and what they can tolerate. As you said, there's a lot to consider in terms of the demands put on them, both their spirit and their bodies. And so I really appreciate everything you're saying. Is there anything that we're missing in this process that you think patients might want to know?
I think you've hit on all of the like major points here. Just that balance can be very, very tricky, and this is why having such a great team here, and a great team with you, Lisa, is so critical in this
Thank you.
process. We are, dependent on, the psych element of this, and we are dependent on the logistics of this, and we are dependent on like a huge team here to make this happen. But in the end, we want everybody to feel comfortable, informed, and we want to be successful.
Yes, yes. And ultimately, we really want everyone to be able to have the healthy baby that they dreamed of. And I guess it's so hard when you're considering all of these factors not to get caught in the weeds, because there's so many things to consider to kind of keep your eye on the prize, that the healthy baby is really the end goal. It must be very difficult as you're considering all of these things along the way.
Yes, for sure. And we see, like many times, we'll see ambivalence, like in that form, where there's a focus on hair color, or focus on eye color, or focus on height, or a focus on like one physical attribute that just has to be there,
Right.
and sometimes we'll see ambivalence like in that form. But I think having patience and just talking patients through it is very helpful.
Yes, absolutely. And so, all of you out there who are listening, I hope you're listening to Dr. Rudick and what she's saying. There's so much that goes into this, and there's so much to think about with regard to this process and the donor's health and your health as a recipient and everybody's long term success. And it sounds like, Dr. Rudick, your process there at Columbia is so thoughtful and so considerate of everybody involved. So, we really appreciate you.
That's our goal. Thank you, Lisa.
You're welcome. And where can people reach you, Dr. Rudick?
So I'm here at the Fertility Center almost every day. I'm one of the few to come in almost every day. I'm on the website as well, and I have an email. I definitely email with all my patients, so patients can usually reach me pretty easily via email.
Okay. And do you mind sharing your email here?
Yeah, so my email is B as in boy, J as in Jennifer, R as in rabbit, 2129 at C as in Columbia, U as in university, M as in medical center, C as in center, .columbia.edu.
Well, thank you. That's very generous of you. And hopefully, all of you out there will take advantage of Dr. Rudick's wonderful generosity. And please subscribe, because, as you know, that's how we keep going. It's so important to have you every week. We have lots and lots to offer you. And please take care of yourself. There's so much to consider on this journey, and we're all here for you. We all have your back. We're all rooting for you. So thank you for your time, and we will see you next week. Hi, it's Lisa Schumann. I hope that you enjoyed that video, and I hope it helped you. And if it did, please give us a thumbs up and subscribe, because that's how we keep going. It's really important to us. And if you liked it, you might like this one.